In the concept functional ability, multiple sclerosis is the exemplar. Multiple sclerosis is an immune-mediated, progressive, demyelinating disease of the central nervous system. Demyelination refers to the destruction of myelin, which is the fatty and protein material that surrounds certain nerve fibers in the brain and spinal cord. It results in impaired transmission of nerve impulses. Clinical manifestations include fatigue, so patients should avoid hot temperatures and rest in cool areas. Depression is one. Weakness. If they have weakness, they should have short rest periods. Numbness is a clinical manifestation. Difficulty in coordination. They need gait training. Loss of balance. Spasticity. Utilizing baclofen and/or benzodiazepines can help with the spasticity. Also, muscle stretching can help. Patients can have pain, which they would utilize analgesics. And another clinical manifestation is visual disturbances.
Cellulitis pathophysiology is an acute streptococcal or staphylococcal infection of the skin and subcutaneous tissue. It is usually caused by Staphylococcus aureus. Now, cellulitis can occur at any age and can involve any skin area on the body. It can occur as an extension of a skin wound, as an ulcer, or from furnicles or carbuncles. Cellulitis can be associated with other diseases, including chronic venous insufficiency or stasis dermatitis. Clinical manifestations of cellulitis in a localized reaction will be erythema, pain, edema, and warmth at the site of the skin disruption. Treatment includes mild cases, usually with cephalexin or amoxicillin clavulanic acid, and in more severe cases, and if it's periorbital or orbital cellulitis, it will require IV cephalosporins. Important factors of cellulitis are educating our parents and our patients if they're adults. We want to educate them in being clean, taking showers, drying appropriately, keeping fingernails short, especially in children, so that if they scratch, even if they scratch because of eczema, that it's not traumatizing the tissue and disrupting and giving a portal of entry for microorganisms. If the skin does disrupt, keeping that area very well cleaned, keeping it dry, and if there is a big skin disruption, that they need to go see a physician to see if they need to have antibiotics, whether it be topical or oral. With bacterial pneumonia, clinical manifestations are abrupt onset of fever, shaking or chills, a cough causing chest pain, purulent sputum, pleuritic type chest pain. When you do a physical assessment, you can hear consolidation of the lungs, and that is usually also manifested within a chest x-ray. Dullness to percussion over affected area with fremitus, because there's something solid, so it sounds dull. Bronchophony, which is abnormal voice sounds heard over the lung with a voice too clear and high-pitched, indicating solidification. Egophony, which is increased resonance of voice sounds with a high-pitched bleeding quality, heard especially over lung tissue compressed by pleural effusion. Bronchial breath sounds and crackles. Viral pneumonias are the most common causes of atypical pneumonia because of a viral infection. It has a gradual insidious onset. Patients can manifest with headaches, sore throats, muscle soreness, fatigue, dry cough, mucus sputum. They don't always have experiencing fever and chills. On physical assessment, you can hear scattered wheezes, crackles, and there may be little or no evidence of consolidation. In a chest x-ray, they may have minimal to substantial bilateral infiltrates. When we do labs, if we look at their white blood cells, they will be depressed slightly, less than 10,000. With pneumonia, we as nurses are going to utilize collaborative care. If it's a viral pneumonia, we do supportive care. We're going to give oxygen if needed, and if so, use a pulse oximetry to monitor. We're going to give hydration, PO, and IV. We're going to use aerosol therapy so that if the bronchioles need to be dilated, we can give medications. We can also use humidification with the oxygen if we need to. We can give antipyretics, antitussives, and antihistamines. We can also give nasal decongestants. Now, one thing that we need to be aware of is our geriatric patients. That supportive treatment also includes hydration, but we need to use with caution and with frequent assessment because they have a risk of fluid overload. In bacterial pneumonia, we're going to give oxygen once again if needed and monitor with pulse oximetry. But then we're also going to give antibiotics, and there's many different types of antibiotics that can be utilized. You have a chart actually in your digital textbook. We're going to give hydration therapy once again, aerosol therapy, and antipyretics. If needed, we can do chest physiotherapy and postural drainage to help facilitate the release and the expectorant of the mucus. Preventative measures is we're going to administer a pneumococcal vaccine and educate the patient to have a pneumococcal vaccine when initiated. Those who are at risk and need the pneumococcal vaccine are chronic illness patients, such as those who have heart and lung disease, those who have diabetes, those recovering from severe illness, 65 years of age or older, and those people who are in long-term care facilities.
Rheumatoid arthritis is an autoimmune disease of unknown origin. The exact mechanism of action for the etiology of rheumatoid arthritis is unknown. However, research has identified that the autoimmune reaction originates in the synovial tissue. It is hypothesized that both environmental factors such as cigarette smoking and genetic factors come together to produce inflammatory and destructive synovial fluid, starting in the more distal joints. The rheumatoid arthritis synovium breaks down collagen, causing edema, proliferation of synovial membrane, and ultimately pannus formation. A pannus is a condition in which a layer of vascular fibrinous tissue extends over the surface of an organ or other specialized anatomical structure. Pannus destroys cartilage and erodes the bone. The consequence is loss of articular surfaces and joint motion. Muscular fibers undergo degenerative changes. Tendon and ligament elasticity and contractile power are lost. In assessing a patient and having diagnostic findings, you will note that the initial clinical manifestations include symmetric joint pain and morning joint stiffness lasting longer than 1 hour. In the early stages, even before the presentation of bony changes, limitation of function can occur when there is active inflammation in the joints. The joints are hot, swollen, and painful, and not easily movable. Immobilization for extended periods can lead to contractures, creating soft tissue deformity. There could be deformities of the hands, like ulnar deviation and swan neck deformity, and feet, which are very common. Rheumatoid arthritis is a systemic disease with multiple extra-articular features. These features most common are fever, weight loss, fatigue, anemia, lymph node enlargement, and Raynaud's phenomena, which is cold and stress-induced vasospasm, causing episodes of digital blanching or cyanosis. The history and physical examination focuses on manifestations such as the bilateral and symmetrical stiffness, tenderness, swelling, and temperature changes in the joints. Arthrocentesis shows synovial fluid that is cloudy, milky, or dark yellow and contains numerous inflammatory components such as leukocytes and complement. Osteomyelitis is an infection of the bone that results in inflammation and necrosis and formation of new bone. More than 50% of bone infections are caused by Staphylococcus aureus, and an increasingly of that variety is methicillin resistant. Other pathogens include the gram-positive organisms of streptococci and enterococci, followed by gram-negative bacteria, including Pseudomonas. The initial response to infection is inflammation, increased vascularity, and edema. After 2 or 3 days, thrombosis of the local blood vessels occur, resulting in ischemia with bone necrosis. The infection extends into the medullary cavity and under the periosteum and may spread into adjacent soft tissues and joints. Unless the infective process is treated promptly, a bone abscess forms. The resulting abscess cavity contains dead bone tissue, which is called the sequestrum, which does not easily liquefy and drain. Therefore, the cavity cannot collapse and heal, as it does not in soft tissue abscesses. Therefore, new bone growth forms and surrounds the sequestrum. Although healing appears to take place, a chronically infected sequestrum remains and produces recurring abscesses throughout the patient's life. This is referred to as chronic osteomyelitis. In acute osteomyelitis, early X-ray findings demonstrate soft tissue edema. An MRI can be performed that will help with early definitive diagnosis. Blood studies reveal leukocytosis and an elevated erythrocyte sedimentation rate. Wound and blood culture studies are performed, although they are only positive in 50% of the cases. With chronic osteomyelitis, the ESR, erythrosedimentation rate, and the WBC count are usually normal. Anemia associated with chronic infection may be evident. Cultures of the blood specimens and drainage from the sinus tract are frequently unreliable for isolating the organism involved. Antibiotic therapy is many times prescribed presumptively. For management, we utilize antibiotics for 3 to 6 weeks. After the infection appears to be controlled, the antibiotic may be administered orally. We also can utilize surgical management. If the infection is chronic and does not respond to antibiotic therapy, surgical debridement is indicated. The infected bone is surgically exposed, the purulent and necrotic material is removed, and the area is irrigated with sterile saline solution.
Chronic obstructive pulmonary disease is a preventable and treatable, slowly progressive respiratory disease of airflow obstruction involving the airways, pulmonary parenchyma, or both. COPD may include diseases that cause airflow obstruction, like emphysema and chronic bronchitis, or any combination of these disorders. Clinical manifestations are chronic cough, sputum production, dyspnea. Long-term clinical manifestations are a barrel chest and clubbing of the fingers. Interventions include teaching to breathing exercises, which is pursed lip breathing, diaphragmatic breathing, teaching to pace activities, teaching self-care activities, exercise, oxygen therapy, nutrition, and coping measures. Medications that are utilized for COPD are bronchodilators and corticosteroids. Bronchodilators receive bronchospasm by altering smooth muscle tone and reducing airway obstruction by allowing increased oxygen distribution throughout the lungs and improving alveolar ventilation. Asthma is a chronic inflammatory disease of the airways that causes airway hyperresponsiveness, mucosal edema, and mucus production. This inflammation ultimately leads to recurrent episodes of asthma symptoms, which include cough, chest tightness, wheezing, and dyspnea. The underlying pathology in asthma is reversible diffuse airway inflammation that leads to long-term airway narrowing. This narrowing, which is exacerbated by various changes in the airway, includes bronchoconstriction, airway edema, airway hyperresponsiveness, and airway remodeling. Now, there are age differences between the adult and the child. The children have narrow airways, which causes a greater increase in airway resistance, which is actually the effort or force needed to remove oxygen through the trachea to the lungs. Children's airways are smaller than adults, and they also have increased friction and resistance increase as air passes through the airway. Oxygen consumption in children is higher due to the metabolic rate being higher. And children also have fewer glycogen reserves, which means their muscles fatigue faster. There are triggers that elicit an asthma exacerbation. Things like smoke, dust mites, pet dander, cockroaches, indoor molds, pollen, and air pollution.
Within the concept of comfort is phantom limb pain. Phantom limb pain would occur because of an amputation. The major goals of a patient for the nurse is to relieve pain, wound healing, acceptance of altered body image, resolution of the grieving process, independence and self-care, restoration of physical mobility, and absence of complications. In relieving pain, the pain may be from incision or may be caused by inflammation, infection, or pressure on a bony prominence. The pain is described as if the amputated limb feels crushed, cramped, or twisted with an abnormal position. The pain sometimes is accompanied by numbness or tingling. The phantom pain occurs intermittently and unpredictably. Those episodes of pain may last for seconds or hours. Opioid analgesics may be effective in relieving this pain. Another intervention is to promote wound healing. The residual limb must be handled gently. Whenever the dressing is changed, aseptic technique is required to prevent wound infection and possible osteomyelitis. Enhancing body image is another intervention. The nurse encourages the patient to look at, feel, and care for the residual limb. It is important to identify the patient's strengths and resources to facilitate rehabilitation. The nurse helps the patient regain the previous level of independent living. In the concept of comfort is sickle cell exemplar. Sickle cell has crises. There are precipitating factors that precipitate a crisis. Cold temperatures, dehydration, low oxygen, infection, and stress can cause a crisis. There are 3 different types of crises. The acute vaso-occlusive crisis, which is the entrapment of red blood cells and white blood cells in microcirculation. This will cause tissue hypoxia, inflammation, and necrosis. Another crisis is called aplastic crisis. This is the infection with human parvovirus. Hemoglobin falls rapidly and marrow cannot compensate. Also, absence of reticulocytes will happen because of this. The third is sequestrian crisis, where organs pool sickled cells. In children, the most common site is the spleen, and in adults, the most common site is the liver. Pain is a significant issue. The incidence of painful sickle cell crises can be variable, and many patients have pain on a daily basis. Adequate hydration is important during the painful sickling episode. Oral hydration is acceptable if they can maintain the adequate fluid intake, or IV hydration can be acceptable. The use of medication to relieve acute pain is important. Aspirin can be useful in diminishing mild to moderate pain, and it also diminishes inflammation and potential thrombosis. Non-steroidal anti-inflammatory drugs are useful for moderate pain or in combination with those opioid analgesics. Pain levels should always be monitored using a pain intensity scale such as 0 to 10, and notifying and recognizing the quality of pain, like sharp, dull, or burning, or the frequency, consistent versus intermittent. Urolithiasis and nephrolithiasis refer to stones, calculi, in the urinary tract and kidney. Stones are formed in the urinary tract when urinary concentrations of substances such as calcium oxalate, calcium phosphate, and uric acid increase. Stones may be found anywhere from the kidney to the bladder and may vary in size from minute granular deposits called sand or gravel to bladder stones as large as an orange. Stone formation is not clearly understood, and there are a number of theories about their causes. One theory relates to fluid volume status of the patient. Stones tend to occur more often in dehydrated patients. Certain factors favor the formation of stones, including infection, urinary stasis, and periods of immobility, all of which slow renal drainage and alter calcium metabolism. With clinical manifestations, signs and symptoms of stones in the urinary system depend on the presence of obstruction, infection, and edema. Stones in the renal pelvis may be associated with an intense, deep ache in the costovertebral region. Hematuria is often present. Pyuria may also be noted. If pain suddenly becomes acute with tenderness over the costovertebral area and nausea and vomiting occur, the patient having an episode of renal colic. Diarrhea and abdominal discomfort are due to renal intestinal reflexes in the anatomic proximity of the kidneys to the stomach, pancreas, and large intestine. With assessment and diagnostic findings, the diagnosis is confirmed by x-rays of the kidneys, ureters, and bladder, which we call KUB, or by ultrasonography, IV urography, and retrograde pylography. Blood chemistries and a 24-hour urine test for the measurement of calcium, uric acid, creatinine, sodium, pH, and total volume are part of the diagnostic workup. Dietary and medication histories and family history of renal stones are obtained to identify factors predisposing the patient to the formation of stones. The goal for renal calculi is that the patient have relief of pain and discomfort, prevention of recurrence of renal stones, and absence of complications. The nursing interventions that are utilized is relieving pain. Severe acute pain is often the presenting symptom of a patient with renal and urinary calculi and requires immediate attention. Opioid analgesic agents, IV or intramuscular, may be prescribed and administered to provide rapid relief along with an IV NSAID. The patient is encouraged and assisted to assume a position of comfort. If activity brings pain relief, the patient is assisted to ambulate. Monitoring managing potential complications. We can increase fluid intake and encourage that to prevent dehydration and increase hydrostatic pressure within the urinary tract to promote passage of the stone. If the patient cannot take adequate fluids orally, IV fluids are prescribed. All urine is strained through gauze because uric acid stones may crumble. Any blood clots passed in the urine could be crushed and the sides of the urinal and bedpan inspected for clinging stones. Because renal stones increase the risk of infection, sepsis, and obstruction of the urinary tract, the patient is instructed to report decreased urine volume, bloody or cloudy urine, fever, and pain. Patients with calculi require frequent nursing observation to detect the spontaneous passage of a stone. The patient is instructed to immediately report any sudden increases in pain intensity because of the possibility of a stone fragment obstructing a ureter. Vital signs including temperature are monitored closely to detect early signs of infection. Urinary tract infections may be associated with renal stones due to an obstruction from the stone or from the stone itself. All infections should be treated with the appropriate antibiotic agent before efforts are made to dissolve the stone. We must educate the patient. Because the risk of recurring renal stones is high, the nurse provides education about the cause of kidney stones and recommendations to prevent the recurrence. If you as the student look on chart 5512, Preventing Kidney Stones, it will help establish the knowledge that is needed. If lithotripsy, percutaneous stone removal, ureteroscopy, or other surgical procedures for stone removal have been performed, the nurse instructs the patient about the signs and symptoms of complication, like urinary retention or infection, that need to be reported to the physician.
If a stone does not pass spontaneously or if complications occur, common interventions include endoscopic or other procedures. For example, ureteroscopy, extracorporeal shockwave lithotripsy, or endourologic percutaneous stone removal may be necessary. Uroscopy involves first visualizing the stone and then destroying it. ESWL is a non-invasive procedure used to break up stones in the calyx of the kidney. After the stones are fragmented to the size of grains of sand, the remnants of the stones are spontaneously voided. Therefore, once again, all urine is strained through gauze because the stones may crumble and be spontaneously voided. Endoneurologic methods of stone removal may be used to extract renal calculi that cannot be removed by other procedures. A percutaneous nephrostomy or percutaneous nephrolithotomy, which are similar procedures, may be performed.
In the exemplar hypokalemia, the serum potassium is less than 3.5 milliequivalents a liter. The contributing factors would be diarrhea, vomiting, gastric suctioning, corticosteroid administration, carbenicillin, amphotericin B, which are medications, bulimia, osmotic diuresis, alkalosis, starvation, diuretics, and digoxin toxicity. The clinical manifestations would be fatigue, anorexia, nausea and vomiting, muscle weakness, polyuria, decreased bowel motility, ventricular asystole or fibrillation, paresthesias, leg cramps, decreased blood pressure, ileus, abdominal distension, hypoactive reflexes. When looking at an ECG, you'll have flattened T waves, prominent U waves, ST depression, and prolonged PR interval. It's helpful to you if you review Table 13.4, page 246, for these contributing factors and for these manifestations. With the concept of fluid and electrolytes, hypernatremia is an exemplar. Hypernatremia can be caused by a gain of sodium in excess of water or by loss of water in excess of sodium. It can occur in patients with normal fluid volume or those with fluid volume deficit. With a water loss, the patient loses more water than sodium, and as a result, the serum sodium concentration increases, and the increased concentration pulls fluid out of the cell. The etiology of hypernatremia can be excess water loss, which can be from burns, third spacing, or emesis. Another etiology is excess sodium administration, diabetes insipidus, heat stroke, or hypertonic IV solutions. A fluid deprivation in unconscious patients who cannot perceive, respond to, or communicate their thirst is also part of the pathophysiology. Less common causes of hypernatremia are heat stroke and near drowning in seawater, or malfunction of hemodialysis or peritoneal dialysis systems. Clinical manifestations include thirst, elevated temperature, dry, swollen tongue, sticky mucosa. Neurologic symptoms include apprehension, restlessness, and weakness. Please note that thirst may be impaired in elderly or the ill. Medical management includes giving back hypertonic electrolyte solution or D5W. It consists of the gradual lowering of the serum sodium level by the infusion of a hypotonic electrolyte solution or an isotonic non-saline solution. Nursing management would include assessment and prevention of hypernatremia, assess for over-the-counter sources of sodium, offer and encourage fluids to meet patient needs, and provide sufficient water if there are tube feedings. With the concept of fluid and electrolyte, fluid volume deficit and hypovolemia is an exemplar. The definition is the loss of extracellular fluid exceeds the intake of fluid. Now, the body has homeostatic mechanisms. It's equipped with remarkable mechanisms to keep the composition and volume of body fluid within narrow limits normal. Organs involved include the kidneys, heart, lungs, pituitary gland, adrenal gland, and parathyroid glands. Other mechanisms is the renin-angiotensin-aldosterone system. Renin is an enzyme that converts angiotensinogen, a substance formed by the liver, into angiotensin. Renin is released by the juxtaglomerular cells of the kidneys in response to decreased renal perfusion. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. The angiotensin 2 has vasoconstrictor properties, and it increases arterial perfusion pressure and stimulates thirst. As the sympathetic nervous system is stimulated, aldosterone is released in response to an increased release of renin, which will decrease urine production. Based on nursing assessment and mechanisms of injury, a likely cause of lower urine output would be the sympathetic nervous system being stimulated and aldosterone being released in response to the increased release of renin. As the sympathetic nervous system is stimulated, aldosterone is released in response to that increased release of renin, which decreases urine production. Management would include giving isotonic solutions. We would monitor INO, which is intake and output, the patient's weight, vital signs, level of consciousness, breath sounds, skin color, and skin turgor. We could give a fluid challenge if they're not excreting enough urine. With dehydration, especially in the elderly, there are normal physiologic changes of aging, including reduced cardiac, renal, and respiratory function and reserve, and alterations of the ratio of body fluids to muscle mass. These may alter the responses of older people to fluid and electrolyte changes. Renal function declines with age, as do muscle mass and daily exogenous creatinine production. Therefore, high normal and minimally elevated serum creatinine values may indicate substantially reduced renal function in older adults. Because of a decrease in age-related muscle mass, older people have a lower concentration of body fluid that may alter physiologic responses. Routine procedures, such as the vigorous administration of laxatives or enemas before colon X-ray studies, may produce a serious fluid volume deficit, necessitating the use of intravenous fluids to prevent hypotension and other effects of hypovolemia. In many older patients, the clinical manifestations of fluid and electrolyte disturbances may be subtle or atypical. For example, fluid deficit may cause delirium in the older person. Rapid infusion of an excessive volume of IV fluids may produce fluid overload and cardiac failure in older patients. Dehydration in older adults is common because of their decreased kidney mass, decreased glomerular filtration rate, decreased renal blood flow, decreased ability to concentrate urine, inability to conserve sodium, decreased excretion of potassium, and a decrease of total body water, loss of subcutaneous supporting tissue, and resultant thinning of the skin occurs with aging. The dermis is dehydrated and loses strength and elasticity. These skin changes affect placement of peripheral IV catheters in older adults. Hypomagnesemia is a serum magnesium level less than 1.8 milligrams per deciliter. Magnesium is similar to calcium in two aspects. First, it is the ionized fraction of magnesium that is primarily involved in neuromuscular activity and other physiologic processes. And second, magnesium levels should be evaluated in combination with albumin levels. Because about 30% of magnesium is protein-bound, principally to albumin, a decreased serum albumin level can reduce the measured total magnesium concentration. For contributing factors in pathophysiology, an important route of magnesium loss is the GI tract. Such loss can occur with nasogastric suctioning, diarrhea, or fistulas. Because fluid from the lower GI tract has a higher concentration of magnesium than fluid from the upper tract, losses from diarrhea and intestinal fistulas are more likely to induce magnesium deficit than those from gastric suctioning. It also may occur with withdrawal from alcohol and administration of tube feedings or parenteral nutrition. Chronic alcohol abuse is a major cause of symptomatic hypomagnesemia. If the enteral or parenteral feeding formula is deficit in magnesium content, serious hypomagnesemia will occur. Because of this, serum magnesium levels should be measured at regular intervals in patients who are receiving parenteral or enteral feedings, especially those who have undergone a period of starvation. Magnesium deficiency often occurs in diabetic ketoacidosis, secondary to increased renal excretion during osmotic diuresis and shifting of magnesium into the cells with insulin therapy. Other causes include administration of certain medications and citrated blood. Clinical manifestations of hypomagnesemia are due directly to the low serum magnesium level. Others are due to secondary changes in potassium and calcium metabolism. Chvostek's and Trousseau signs occur in part because of accompanying hypocalcemia. Hypomagnesemia may be accompanied by marked alterations in psychologic status. Apathy, depressed mood, apprehension, and extreme agitation may be noted, as well as ataxia, dizziness, insomnia, and confusion. At times, delirium, auditory or visual hallucinations, and frank psychosis may occur. Magnesium deficiency can disturb the ECG by prolonging the QRS, depressing the ST segment, and predisposing to cardiac dysrhythmias. Medical management for mild magnesium deficiency can be corrected by diet alone. Principal dietary sources of magnesium include green leafy vegetables, nuts, seeds, legumes, whole grains, seafood, peanut butter, and cocoa. If necessary, magnesium salts can be administered orally in an oxide or gluconate form to replace continuous losses, but can produce diarrhea. Patients receiving parenteral nutrition require magnesium in the IV solution to prevent hypomagnesemia. For nursing management, observation is essential. Nurses must observe for signs and symptoms. If hypomagnesia is severe, seizure precautions are implemented, and other safety precautions are instituted if confusion is observed. Patient education plays a major role in treating magnesium deficit. The patient is educated about the sources of magnesium-rich foods. In the concept of elimination, diverticulitis is an exemplar. Diverticulitis results when food and bacteria retained in the diverticulum produce infection and inflammation that can impede drainage and lead to perforation or abscess formation. Signs and symptoms of diverticulosis are diarrhea, nausea, and anorexia. They can also have bloating or abdominal distension. Weakness, fatigue, and anorexia are common. With diverticulitis, the patient reports an acute onset of mild to severe pain in the left lower quadrant, accompanied by nausea, vomiting, fever, chills, and leukocytosis. This condition, if left untreated, can lead to peritonitis and septicemia. Complications of diverticulitis include peritonitis, abscess formation, fistulas, and bleeding. If you have complications, you must notify your physician immediately. If there's perforation, clinical manifestations would be abdominal pain, tenderness, abdominal rigidity, increased white blood cell, increased erythrosedimentation rate, increased temperature, tachycardia, and hypotension. If there's abdominal pain and rigid board-like abdomen, loss of bowel sounds, these signs and symptoms of shock occur with peritonitis. That would also include clinical manifestations of pain, tender and distended abdomen, which is also rigid, tachycardia, and hypotensive. Another complication is hemorrhage, and the last complication would be obstruction. In the concept of elimination, the exemplar diarrhea, which also encompasses Clostridium difficile. Infectious diarrhea results from infectious agents invading the intestinal mucosa. C. difficile is the most commonly identified agent in antibiotic-associated diarrhea in the hospital. Complications of diarrhea include the potential for cardiac dysrhythmias because of significant fluid and electrolyte loss, especially loss of potassium. Loss of bicarbonate with diarrhea can also lead to metabolic acidosis. Complications also can be muscle weakness, paresthesia, hypotension, anorexia, and drowsiness with, once again, those low potassium levels less than 3.5. Assessment and diagnostics findings would include checking for your complete blood count, serum chemistries, urinalysis, and stool examination for infections, parasites, bacterial toxins, blood, fat, and electrolytes.
The concept of elimination with the exemplar diarrhea Clostridium difficile, we have medical management. Management is directed at controlling symptoms, preventing complications, and eliminating or treating the underlying cause. Until the definitive cause is discovered, infection control measures that restrict the transmission of infectious organisms are warranted, such as our contact precautions and hand washing with soap and water. Do not use alcohol-based. Certain medications, such as antibiotics and anti-inflammatory agents and antidiarrheals, will be used to reduce the severity of the diarrhea and treat the underlying disease. In most cases, loperamide is the medication of choice because it has fewer side effects than the diphenoxylate with atropine. Notably, antidiarrheal agents should not be used until C. difficile infection is ruled out. With our nursing management, the nurse's role includes assessing and monitoring the characteristics and pattern of diarrhea.
And SaO2 tells you the oxygenation in pulse ox, by pulse ox. Okay, so I'm not going to review this again, but the steps for blood gas interpretation, you need to identify if it's acidotic or alkalotic. So anything below 7.35 is acidosis, and anything greater than 7.45 is alkalosis. So big thing with this is that when we look and we identify if it's acidosis or alkalosis, then we need to look at our PaCO2 and then our bicarb. And whichever one is altered, we'll look at it, and we have to look at the direction that each component is going. So for example, if I have a low pH and a low bicarb, then I know that it's a metabolic issue because it's going in the same direction. If I had a low pH and a high CO2, then I know that it's a respiratory component. Okay, so we need to look and make sure first at each piece and identify acidosis or alkalosis, and then look at the bicarb and the PCO2 and see which one is affected and what direction it's going. And so a good acronym that you can use is ROAM. Respiratory moves in opposite direction of pH. Okay? So just think of that, and then you'll always remember. Respiratory alkalosis is when the pH is high and the PaCO2 is low. Parameters. So how do we do that? We do that by using our two systems, the lungs and the kidneys. Just like when we talked about with shock, we said that because the kidneys shut down, we're not reabsorbing sodium, the sodium bicarb, so that puts us in metabolic acidosis. So this just kind of reinforces this, because this is an exemplar of metabolic acidosis, would be shock. Okay, lungs would be the regulators for the CO2 component. Okay, so our lungs help just by increasing or decreasing the rate of respiration to regulate the amount of CO2 in our blood. So the physiological buffers for each component are the lungs and the renal abilities. The lungs help regulate the acid component of the part of the pH balance. So pretty much the lungs are associated with the CO2. How do the lungs help? Well, they either increase or decrease the rate of breathing. So they'll either breathe slower or deeper in response to the pH. Okay? So that is pretty much how the lungs compensate. Renal, what will happen is if for example, there's an excessive amount or too little amount, it will either help by excreting the amount of bicarb, or help so the kidneys can either produce or excrete the bicarb of whatever is needed. So pretty much they're like the regulatory systems of the body to maintain pH balance. So when the PaCO2 is low, that means that there's not enough CO2 in the blood. So when we think of patients that are anxious, they're hyperventilating. Okay, so a lot of times they're breathing so fast that they're getting rid of all the CO2. So when that happens, usually we'll see it with patients that are anxious, they're hypoxemia, they've had like a salicylate intoxication, they may be pregnant. A big thing with this respiratory alkalosis we can see with pregnancy, because what happens is the uterus pushes up to the diaphragm, and it compresses up to the chest, and it kind of makes it harder for the lungs to expand. So the women that are pregnant, they breathe faster because that's their way of compensating for the anatomical changes that are occurring. Another thing we can also see with respiratory alkalosis, if our ventilatory settings aren't changed. So this is why we do ABGs routinely, is because a lot of times if the rates are off and the gases aren't in sync with the vent settings, we may need to change them. Okay, So, what do we see with some indications of respiratory alkalosis? You'll see numbness and tingling, inability to concentrate. You'll see loss of consciousness. You'll see tachycardia and ventricle and atrial dysrhythmias. Okay, so there's a lack of CO2, so you're going to have an alteration, and see here that a lot of times if you see that you're losing CO2, you're going to see that you're going to lose, you're going to have a deficit in your potassium. Okay, so that's important. So when you're looking at, in terms of respiratory alkalosis, you're going to see an anxious patient. So what are you going to do? You're going to have them stop and breathe through a paper bag because you want them to rebreathe that CO2, right? You're going to have them calm down. You'll give them anti-anxiety medications. You'll give them Xanax to calm them down. If it's a patient on a ventilator, you'll slow down the rate on the ventilator. Respiratory acidosis is when there's an inadequate excretion of CO2. So there's too much CO2 and there's a low pH. And so what happens, usually we'll see patients with pulmonary edema, aspiration, atelectasis, like if they're in respiratory distress, you'll see that. Sleep apnea, a pneumothorax, anything altering the pulmonary system, you're going to see respiratory acidosis. So typically when we have too much CO2 in our blood, if that happens, it's a vasoconstrictor. So what happens is we're going to have increased pulse, respirations, blood pressure, altered confusion, fullness of the head, and altered level of consciousness. So this just kind of tells you where what respiratory acidosis is, okay? And so in turn, you're going to see hyperkalemia, okay? So you'll see decreased blood pressure with vasodilation, rapid shallow respiration, headache, dysrhythmias due to potassium. So all these different alterations and changes.
With acid-base disturbances, plasma pH is an indicator of hydrogen ion concentration and measures the acidity or alkalinity of the blood. Homeostatic mechanisms keep pH within a normal range. These mechanisms consist of buffer systems, the kidneys, and the lungs. Buffer systems prevent major changes in the pH of body fluids by removing or releasing hydrogen. They can act quickly to prevent excessive changes in hydrogen concentration. Hydrogen ions are buffered by both intracellular and extracellular buffers. The body's major extracellular buffer system is the bicarbonate. Boom.
Before I forget, vomiting, gastric suction, and pyloric stenosis. Pyloric stenosis is where there is a narrowing of the pyloric sphincter, and it makes it harder. Usually the patients have frequent emesis. They have frequent emesis, and they lose a lot of electrolytes. So with pyloric stenosis, usually they'll need corrective surgery. So they'll always, before they're diagnosed, their ABG will come back with metabolic alkalosis. Okay. Some of the things that we want to do is we want to monitor intake and output because they are vomiting, so they're losing electrolytes, and we're just going to push them with fluids. Okay, we'll give them normal saline fluids because we want to hydrate them, and we also want to make sure if there's a deficit in their potassium levels that we give them potassium chloride. Also, a lot of times too, what we'll do is we'll have H2 receptor antagonists, which are Tagamet, which kind of help us hold on to the hydrochloric acid so we don't lose it anymore.
In coronary artery disease, angina is usually caused by atherosclerotic disease. Almost invariably, angina is associated with a significant obstruction of at least one major coronary artery. Normally, the myocardium extracts a large amount of oxygen from the coronary circulation to meet its continuous demands. When demand increases, flow through the coronary arteries needs to be increased. When there is a blockage in a coronary artery, flow cannot be increased and ischemia results. There are several factors associated with typical anginal pain. There's physical exertion, which precipitates an attack by increasing myocardial oxygen demand. There is also exposure to cold, which causes vasoconstriction and elevated blood pressure with increased oxygen demand. Also, eating a heavy meal that increases the blood flow to the mesenteric area for digestion, thereby reducing the blood supply available to the heart muscle. In a severely compromised heart, shunting of blood for digestion can be sufficient to induce anginal pain. And fourth, stress or any emotion-provoking situation, causing the release of catecholamines, which increases blood pressure, heart rate, and myocardial workload. A person with angina pectoris has a feeling of weakness or numbness in the arms, wrists, and hands, as well as shortness of breath, pallor, diaphoresis, dizziness, or lightheadedness, and nausea and vomiting. An important characteristic of angina is that it subsides with rest or administering nitroglycerin. Medical management of angina are to decrease the oxygen demand of the myocardium and to increase the oxygen supply. Nitrates, or nitroglycerin, are a standard of treatment for angina pectoris. Nitroglycerin is a potent vasodilator that improves blood flow to the heart muscle and relieves pain. Nitroglycerin dilates primarily the veins and, to a lesser extent, the arteries. In self-administering nitroglycerin, the nurse must discuss potential side effects of nitroglycerin, which include flushing, throbbing headache, hypotension, and tachycardia. When a nurse comes into the ER or on the floor and a patient complains of angina, they must treat immediately. The patient experiencing angina is directed to stop all activities and sit or rest in bed in a semi-phalanx position to reduce the oxygen requirements of the ischemic myocardium. In the hospital, a 12-lead ECG is usually obtained and assessed for ST segment and T wave changes. If a patient has been placed on cardiac monitoring with continuous ST segment monitoring, the ST segment is assessed for changes. We also must give the nitroglycerin. It's administered sublingually and the patient's response is assessed. The response hopefully would be relief of chest pain, and it would affect the blood pressure and heart rate. If the chest pain is unchanged or is lessened but still present, nitroglycerin administration is repeated up to 3 doses. Oxygen is usually administered at 2 liters by nasal cannula, even without evidence of desaturation, although there is no current evidence of a positive effect on patient outcome. If the pain is significant and continues after these interventions, the patient is further evaluated for acute myocardial infarction and may be transferred to a higher acuity nursing unit.
So what do we do for this? Well, we don't want to add more pressure to the heart because the pressure already is there because the fluid's not making its way in and out of the body. So what do? We try to maintain the blood pressure and help relax those vessels to make it easier for the heart to work. Okay? So we do this by doing the ACE inhibitors because we want to stop the angiotensin conversion enzyme, which is reabsorbing the sodium in the water. We can also use angiotensin receptor blockers, which are the same. They do the same effect. So this is the Diovan would be an example. You can use beta blockers or hydralazine, and it's pretty much just to ease the workload of the heart. But the biggest thing with congestive heart failure, if you think about it, if a patient's heart is in right-sided failure, do we want to allow them to consume 3 liters of water? No, we don't. Because it's already backing up into the other side and creating systemic issues. So why would we encourage fluids? So a big thing with congestive heart failure is we want to limit the amount of fluids and make sure they're getting rid of any excessive fluids. So a lot of times these patients are on loop diuretics and the Lasix, and pretty much that kind of stops the sodium and the chloride to being absorbed. With diuretics, you want to make sure you're paying close attention to lab values because you can see alterations in your potassium levels. You also want to make sure anytime you're administering loop diuretics, you assess their blood pressure because the blood pressure, a lot of times they'll have hypotension. So we don't want to give them Lasix when they're already low on their blood pressure because that's going to wipe them and bring them completely down. Okay? So we don't want to do that. And we also want to make sure that they're urinating as much as what we want. If we're giving them a diuretic, we by right need to see output coming off. If there's no output coming off, then we have a problem. So we need to look at that in terms of making sure whatever they're taking in, they're letting off, and that the Lasix is effective, because there is a lot of times we have to change our dosages of Lasix to meet the needs of the patient. What we usually see with the mitral valve prolapse is that it's not. What happens is that valve is not functioning correctly, and so it promotes promotes blood to go from the left ventricle back up in the left atrium. Okay, and so it kind of makes it more difficult. It doesn't keep it enclosed, if that makes sense. So typically what we see are some of the signs and symptoms are fatigue, shortness of breath, lightheadedness, dizziness, syncope, palpitations, chest pain, and anxiety. The important thing what you want to know is that somebody that has a mitral valve insufficiency, you won't see these symptoms all the time. So that's important method. That's an important instruction for you to include with your patients, because a lot of times if there's an indication that their mitral valve has, if there's a compromise at all in the patient, then you'll see these changes. If it's exacerbated.
The concept perfusion includes coronary artery disease, which we'll be discussing in myocardial infarction. The inflammatory process involved in the development of atherosclerosis begins with injury to the vascular endothelium and progresses over many years. A thrombus can form, which then will obstruct blood flow, leading to acute coronary syndrome, which may result in acute myocardial infarction. When a myocardial infarction occurs, a portion of the heart muscle no longer receives blood flow and becomes necrotic. Coronary artery disease produces symptoms and complications according to the location and degree of the narrowing of the arterial lumen, thrombus formation, and obstruction of blood flow to the myocardium. This impediment to blood flow is usually progressive, causing an inadequate blood supply that deprives the cardiac muscle cells of oxygen needed for their survival. This condition is known as ischemia. Angina pectoris refers to chest pain. Clinical manifestations would include that all ages and genders would have ischemia, angina pectoris or chest pain, epigastric distress, pain that radiates to the jaw or left arm, and shortness of breath. What are atypical symptoms, and mostly for women, is indigestion, nausea, palpitations, and numbness.
Okay. The inverse of that is hypertension. So hypertension is opposite. Hypertension is when there's a lot of resistance in the blood vessels due to, sodium or water or even atherosclerosis that kind of makes it harder for that blood flow to go through the vessel. So ideally what we want is a blood pressure less than 140 and less than 90. But typically, anytime a patient has two consistent readings of 140 over 90, they're labeled hypertension. So some of the manifestations of hypertension, just think about it. If it's affecting vessels, a lot of times they're going to have alterations in their small vessels and large vessels. So you'll see changes in their eyes. You'll see a lot of times the major vessels in the heart are compromised and they aren't able to get the oxygenation that they need, and that can lead to an MI or stroke. So all those different things, this is why we want to make sure that we are very aggressive with hypertension, because we want to avoid these things. So what are we going to do for these patients? We're going to encourage them to be proactive. We're going to have them monitor their blood pressure daily. We're going to keep them on a weight management program, encourage exercise. We're going to limit the amount of salt they take, because the salt is going to make it difficult for those vessels to make its way and to get perfused. And we want to make sure that they're not encouraging any alcohol consumption. Okay? As far as treatments, we're going to be looking at blood pressure medications to kind of help regulate regulate the tension in the vessels. And also, we're looking at diuretics to remove any excess fluid. So a lot of times in combination therapy, they'll use these. So great. Okay. Venous thrombosis, we see this a lot at warm springs, post-surgery, impaired mobility, any kind of patient where they're not moving around, or there's a possibility there's post-surgery because there's a lot of blood loss or alterations in if they have issues with their bleeding, or if they're on aspirin. No, not aspirin, sorry. If they're on Lovenox helps it, I'm sorry. But if there's an issue where they're immobile, or if they've post-surgery, they're at high risk of developing a clot in their legs. And so a lot of times what happens... Okay, so hemophilia is, it's a factor VIII deficiency. It's an X-linked recessive disorder. And what happens is that a lot of times with this we have to do a lot of patient teaching, because it is something that we have to administer at home, factor VIII. And so a big thing what we want to do is educate the families on injury prevention, because what happens is it makes them more susceptible to bleeding. Okay? So anytime they're around, a lot of times with kids, we'll tell them to put helmets on, we'll tell them to put knee pads on to protect them from injury. For adults, we'll just educate them and tell them, like we won't ever tell them not to be doing contact sports, because that'll increase their likelihood of them getting injured. So we don't want that to happen. So we have to keep them very informed and aware that injury is something we don't want, because what happens is it can bleed in between the joints and can cause a lot of pain. Okay? We want to tell them to avoid NSAIDs like aspirin, because that increases their bleeding. Dental hygiene is important because of their risk for bleeding. We don't want to have to use any kind of implants or anything like that, because it'll increase their susceptibility of bleeding. First aid, we want anytime any kind of small cut or opening, we're going to apply pressure for at least a minute to make sure that the patient stops bleeding. Okay, because the likelihood of them bleeding is great. Okay. So the treatment of choice is the recombinant factor VIII administration. We use this more than the fresh frozen plasma. So we'll do the recombinant factor first, factor VIII. Okay?
The concept of metabolism concerning the exemplar diabetes mellitus, which is classified into different types. There is diabetes type 1, diabetes type 2, gestational diabetes, and diabetes associated with other conditions or syndromes. For example, a woman with gestational diabetes may, after delivery, move into the diabetes mellitus type 2 category. Prediabetes is classified as impaired glucose tolerance or impaired fasting glucose, and refers to a condition in which blood glucose concentrations fall between normal levels and those considered diagnostic for diabetes. Now, insulin is the hormone secreted by the beta cells, which are one of the 4 types of the islets of Langerhans in the pancreas. Insulin is an anabolic or storage hormone, and when a person eats a meal, insulin secretions increases and moves glucose from the blood into the muscle, liver, and fat cells. In those cells, insulin has the following actions: transport and metabolizes glucose for energy, stimulates storage of glucose in the liver and muscle in the form of glycogen, and signals the liver to stop the release of glucose. Now, there are risk factors for diabetes mellitus. First is the family history of diabetes. Second, obesity. Third, race and ethnicity, with African Americans and Hispanic Americans, Native Americans, Asian Americans, and Pacific Islanders. Age greater than 45, but that doesn't always consider the same as the type 1 diabetes mellitus. Previously identified impaired fasting glucose or impaired glucose tolerance tests, which has to do with gestational diabetes. Hypertension greater than 140 systolic. High density lipoprotein cholesterol levels or triglyceride levels, and history of gestational diabetes or delivery of a baby over 9 pounds. Now, within this type 1 diabetes mellitus, there are some symptoms, clinical manifestations that will be found. One is polyuria, which is frequent urination. Second is polydipsia, which is excessive thirst. And third is polyphagia, which is excessive hunger. These individuals will drink, eat, and urinate, and they don't understand why. It's because their body is asking them to do those things to get the glucose in their cells and energy, and it's not going to work. So they end up with weight loss, they end up with fatigue, and they end up with weakness. With type 2 diabetes, it affects approximately 90 to 95% of people with the actual diabetes disease. It occurs more commonly in young people who are older than 30 years of age and obese. There are two main problems related to the insulin in type 2 diabetes are insulin resistance and impaired insulin resistance. Normally, a person without disease, insulin binds to special receptors on cell surfaces and initiates a series of reactions involved in glucose metabolism. In type 2 diabetes, these intracellular reactions are diminished, making insulin less effective at stimulating glucose uptake by the tissues and at relating glucose release by the liver. Now, the exact mechanism that leads to insulin resistance and impaired insulin secretion in type 2 diabetes are unknown, although genetic factors are thought to play a key role. So the patient's pancreas continues to produce some endogenous insulin, and the insulin produced is insufficient or is poorly utilized by the tissues. For type 2 diabetes, obesity is the most powerful risk factor. For most patients, type 2 diabetes is detected incidentally. One consequence of undetected diabetes is that long-term diabetes complications such as eye disease, peripheral neuropathy, peripheral vascular disease may have developed before the actual diagnosis of diabetes is made, signifying that the blood glucose has been elevated for a time before diagnosis. Type 2 diabetes is associated with a slow progressive glucose intolerance, and its onset might go undetected, as I stated, for many years. If the patient's symptoms are experienced, they are frequently mild and may include the fatigue, irritability, polyuria, polydipsia, and poorly healing skin wounds, vaginal infections, or blurred vision if glucose levels are very high. Now, once again, this may be also the etiology and pathology from genetic mutations, as we stated earlier, that led to insulin resistance, and once again, that increased risk for obesity. For both type 1 and type 2 diabetes mellitus, the nursing and collaborative management care goal is to normalize insulin activity and blood glucose levels to reduce the development of vascular and neuropathic complications. The patient's goals are also for diabetes management to achieve normal blood glucose levels without hypoglycemia while maintaining a high quality of life. Therefore, diabetes management has 5 components: nutrition therapy, exercise, monitoring, pharmacologic therapy, and education. It involves constant assessment and modification of the treatment plan by health professionals and daily adjustments in therapy by the patient. Although the healthcare team directs the treatment, it is the individual patient who must manage the complex therapeutic regimen. Therefore, patient and family education is an essential component of diabetes treatment and is as important as all other components of the regimen. For both type 1 and type 2 diabetes, during periods of physiologic stress such as surgery, blood glucose levels tend to increase because levels of stress hormones, which are epinephrine, norepinephrine, glucagon, cortisol, and growth hormone increase. If hyperglycemia is not controlled during surgery, the resulting osmotic diuresis may lead to excessive loss of fluids and electrolytes. Patients with type 1 diabetes are also at risk for developing ketoacidosis during periods of stress. During the postoperative period, patients with diabetes must also be closely monitored for cardiovascular complications because of the increased prevalence of atherosclerosis, wound infections, and skin breakdown. What must be maintained is adequate nutrition and blood glucose control to promote the wound healing. With clinical management of type 1 and type 2 diabetes, primary prevention is essential. It is also the management if you do have type 1 or type 2 diabetes. The areas of focus would be diet, exercise, and weight control. Nutritional, meal planning, and weight control and increased activity are the foundation of diabetes management. The most important objectives in the dietary and nutritional management of diabetes are control of total caloric intake to attain or maintain a reasonable body weight, control of blood glucose levels, and normalization of lipids and blood pressure to prevent heart disease. Success in this area alone is often associated with reversal of hyperglycemia in type 2 diabetes. For exercise, what the main goal would be is to manage diabetes because of its effects of lowering blood glucose and reducing cardiovascular risk factors with exercise. Exercise lowers those blood glucose levels by increasing the uptake of glucose by body muscles and by improving insulin utilization. It also improves circulation and muscle tone. Resistance training, such as strength training, weightlifting, can increase lean muscle mass, thereby increasing the resting metabolic rate. These effects are useful in diabetes in relation to losing weight, easing stress, and maintaining a feeling of well-being. Now, there are some considerations for exercise in people with diabetes. They can exercise 3 times each week with no more than 2 consecutive days without exercise. They can exercise at the same time of each day and the same duration for each session. Important to use proper footwear and, if appropriate, protective equipment. Avoid trauma to the lower extremities, especially in patients with numbness due to peripheral neuropathy. Inspect the feet daily after exercise. Avoid exercise in extreme heat or cold, and avoid exercise during periods of poor metabolic control. In people with type 2 diabetes who are overweight or obese, exercise in addition to dietary management improves glucose metabolism and enhances loss of body fat. Exercise coupled with weight loss improves insulin sensitivity and may decrease the need for insulin or oral anti-diabetic agents. Eventually, the patient's glucose tolerance may return to normal. For type 1 diabetes, the meal plan must consider the patient's food preferences, lifestyle, usual eating times, ethnic and cultural backgrounds. Patients who require insulin to help control blood glucose levels, maintaining as much consistency as possible in the amount of calories and carbohydrates ingested at each meal is essential. In addition, consistency in the amount time intervals between meals with the addition of snacks if necessary helps prevent hypoglycemic reactions and maintain overall blood glucose control. Blood glucose monitoring is a cornerstone of diabetes management, and self-monitoring of blood glucose levels has dramatically altered diabetes care. For type 1 diabetes, exogenous insulin must be administered for life because the body loses the ability to produce insulin. Chart 51.9, Guidelines to Follow During Periods of Illness, Sick Day Rules, in Hinkle, page 1444, is wonderful to help a nurse educate patients. We educate the patient to take insulin or oral antidiabetic agents as usual. They need to test their blood glucose and urine ketones every 3 to 4 hours. They need to report elevated glucose levels as specified or ketones in the urine. If a patient takes insulin during periods of illness, they may need supplemental doses of regular insulin every 3 to 4 hours. If they vomit, have diarrhea, or fever, they need to have liquids. They need to have every half to 1 hour to prevent dehydration and to provide calories. They must report nausea, vomiting, and diarrhea because extreme fluid loss can be dangerous. And if they're unable to retain oral fluids, they might have to be hospitalized to avoid diabetic ketoacidosis and possibly a coma. They would never eliminate their insulin when they have nausea and vomiting. Consistently following a meal plan is one of the most challenging aspects of diabetes management. It may be more realistic to restrict calories only moderately. For patients who have lost weight, incorporating new dietary habits into their lifestyles, diet education, behavioral therapy, group support, and ongoing nutrition counseling are encouraged to maintain weight loss. In type 2 diabetes, insulin may be necessary on a long-term basis to control glucose levels if meal planning and oral agents are ineffective or when insulin deficiency occurs. In addition, some patients in whom type 2 diabetes is usually controlled by meal planning alone or by meal planning and an oral anti-diabetic agent may require insulin temporarily during illness, infection, pregnancy, surgery, or some other stressful event. People with type 2 diabetes who are overweight or obese, exercise in addition to dietary management both improves glucose metabolism and enhances loss of body fat. Exercise coupled with weight loss improves insulin sensitivity and may decrease the need for insulin or oral anti-diabetic agents. Calorie-controlled diets are planned by first calculating a person's energy needs and caloric requirements based on age, gender, height, and weight. Patients may be underweight at the onset of type 1 diabetes because of rapid weight loss from severe hyperglycemia. The goal initially may be to provide a higher calorie diet to regain lost weight and blood glucose control. The recommended level for caloric intake is 50 to 60% of calories should be derived from carbohydrates, 20% to 30% from fat, and the remaining 10% to 20% from protein. Carbohydrates. The caloric distribution currently recommended is higher in carbohydrates than in fat and protein. In general, carbohydrate foods that have the greatest effect on blood glucose levels because they are more quickly ingested than other foods and are converted into glucose rapidly. Carbohydrates consist of sugars and starches. Low glycemic index diets may reduce postprandial glucose levels. Therefore, the nutrition guidelines recommend that all carbohydrates should be eaten in moderation to avoid high postprandial blood glucose levels. Foods high in carbohydrates, such as sucrose, are not totally eliminated from the diet, but should be eaten in moderation because they are typically high in fat and lack vitamins, minerals, and fiber. The recommendations regarding fat content of the diabetic diet include both reducing the total percent of calories from fat sources to less than 30% of total calories and limiting the amount of saturated fats to 10% of total calories. Regarding protein, the meal plan may include the use of some non-animal sources of protein, like legumes and whole grains, to help reduce saturated fat and cholesterol intake. The concept of metabolism with the exemplar diabetes has long-term complications. There are macrovascular complications and microvascular complications. Diabetic macrovascular complications result from changes in the medium to large blood vessels. Blood vessel walls thicken, sclerose, and become occluded by plaque that adheres to the vessel walls. Eventually, blood flow is blocked. The macrovascular complications are coronary artery disease, which they can have a myocardial infarction, cerebrovascular diseases, where they can have transient ischemic attacks or strokes, and also peripheral vascular disease. Microvascular complications can be characterized by capillary basement membrane thickening. The basement membrane surrounds the endothelial cells of the capillary. These microvascular complications can be diabetic retinopathy. Diabetic retinopathy is the leading cause of blindness among people between 20 and 74 years of age in the United States, and it occurs in both type 1 and type 2 diabetes. Another microvascular complication is nephropathy. Nephropathy, or kidney disease, is secondary to diabetic microvascular changes in the kidney. It is a common complication of diabetes. Hyperthyroidism, a common endocrine disorder, is a form of thyrotoxic psychosis, resulting from an excessive synthesis and secretion of endogenous or exogenous thyroid hormones by a thyroid. The most common cause is Graves' disease. Graves' disease is the most common cause of hyperthyroidism. It is an autoimmune disorder that results from excessive output of thyroid hormones caused by abnormal stimulation of the thyroid gland by circulating immunoglobulins. This disease affects women 8 times more frequently than men, with onset usually between the 2nd and 4th decades. This disorder may appear after an emotional shock, stress, or an infection, but the exact significance of these relationships is not understood. The presenting symptom is often nervousness. These patients are often emotionally hyperexcitable, irritable, and apprehensive. They cannot sit quietly, and they suffer from palpitations. Their pulse is abnormally rapid at rest, as well as on exertion. They tolerate heat poorly and perspire unusually freely. The skin is flushed continuously, with the characteristic salmon color in Caucasians, and is likely to be warm, soft, and moist. A fine tremor of the hands may be observed, and patients exhibit exophthalmos, which is abnormal protrusion of one or both eyeballs, or as we call it, bulging eyes. Other manifestations include an increased appetite and dietary intake, weight loss, fatigability and weakness, amenorrhea, and changes in bowel function. In hyperthyroidism, medical management depends on the underlying cause and often consists of a combination of therapies, including antithyroid agents, radioactive iodine, and surgery. The treatment of hyperthyroidism is directed toward reducing the thyroid hyperactivity to relieve symptoms and preventing complications. The use of radioactive iodine is the most common form of treatment for Graves' disease. Beta-adrenergic blocking agents, like propanol or atenolol, are used as adjunctive therapy for symptomatic relief, particularly in transient thyroiditis. Surgical removal of the entire thyroid gland or part of it is a non-pharmacological agent. The 3 treatments, radioactive iodine therapy, antithyroid medications, and surgery, share the same complications: relapse or recurrent hyperthyroidism and permanent hypothyroidism. A nursing intervention is also improving nutritional status. Hypothyroidism affects all body systems, including the GI system. The appetite is increased, but may be satisfied by several well-balanced meals of small size, even up to 6 meals a day. Fluid and foods are selected to replace fluid loss through diarrhea and diaphoresis, and to control the diarrhea that results from increased peristalsis. Rapid movement of food through the GI tract may result in nutritional imbalance and further weight loss. To reduce diarrhea, highly seasoned foods and stimulants such as coffee, tea, and cola and alcohol are discouraged. High-calorie, high-protein foods are encouraged. The clinical manifestations of hypothyroidism are many. Extreme fatigue makes it difficult for the person to complete a full day's work or participate in usual activities. There are reports of hair loss, brittle nails, and dry skin are very common, and numbness and tingling of the fingers may occur. On occasion, the voice may become husky and the patient may complain of hoarseness. Menstrual disturbances, such as menorrhagia or amenorrhea, may occur. Hypothyroidism affects women more frequently than men and occurs most often between ages 40 to 70 years of age. Severe hypothyroidism results in subnormal body temperature and pulse rate. The patient usually begins to gain weight even without increase in food intake, although he or she may be cachectic. The skin becomes thick, the hair thins and falls out, and the face becomes expressionless and mask-like. The patient often complains of being cold, even in a warm environment. The patient may be irritable and complain of fatigue, but as the condition progresses, the emotional responses are subdued. The mental process becomes dulled, and the patient appears apathetic. Speech is slow, the tongue enlarges, the hands and feet increase in size, and even deafness may occur. The patient frequently complains of constipation. Severe hypothyroidism is associated with elevated serum cholesterol level, atherosclerosis, coronary artery disease, and poor left ventricular function. The patient with hypothyroidism that is advanced is hypothermic and abnormally sensitive to sedative, opioid, and anesthetic agents, which must be administered with extreme caution. Patients with unrecognized hypothyroidism who are undergoing surgery are at increased risk for intraoperative hypotension, postoperative heart failure, and altered mental status. Causes of hypothyroidism include autoimmune disease, like Hashimoto's thyroiditis or post-Graves' disease, atrophy of the thyroid gland with aging, therapy for hyperthyroidism, which would include radioactive iodine or thyroidectomy, medications which include lithium, iodine compounds, or antithyroid medications, procedures such as radiation to head and neck and treatment for head and neck cancers, like lymphoma, can also produce hypothyroidism. Infiltrative diseases of the thyroid can also cause hypothyroidism. And then, of course, iodine deficiency and iodine excess can cause hypothyroidism. Treatment for hypothyroidism includes the medical management with the objectives of hypothyroidism to restore a normal metabolic state by replacing the missing hormone, as well as prevention of disease progression and complications. Synthroid or levothyroid is commonly prescribed for treating hypothyroidism and suppressing non-toxic goiters. Its dosage is based on the patient's serum thyroid-stimulating hormone concentration. If replacement therapy is adequate, the symptoms of myxedema disappear and normal metabolic activity is resumed. Although rare, if the disease progresses to myxedema coma, IV administration of T4 and T3 are recommended rather than T4 alone. T4 is administered IV until the patient is able to safely take T4 in oral form. T3 is administered IV until the patient is stable. Administration of high-dose glucocorticosteroids every 8 to 12 hours for 24 hours, followed by a low-dose therapy is recommended until coexisting adrenal insufficiency is ruled out. Prevention of cardiac dysfunction is important, as well as prevention of medication interactions. Oral thyroid hormones interact with many other medications. There is a decrease in thyroid hormone absorption when patients are taking magnesium-containing antacids. Thyroid hormones may also decrease the pharmacological effects of digitalis. Doses of anticoagulant agents need to be decreased when beginning thyroid replacement because of the increased risk of bleeding. Even in small IV doses, hypnotic and sedative agents may induce profound somnolence, lasting far longer than anticipated and leading to narcosis. In adrenal hormone excess, there is Cushing's syndrome. They call it hypercortisolism. Now, the causes are results from excessive rather than deficient adrenocortical activity. Cushing's syndrome is commonly caused by the use of corticosteroid medications and is infrequently the result of excessive corticosteroid production secondary to hyperplasia of the adrenal cortex. However, overproduction of endogenous corticosteroids may be caused by several mechanisms, including a tumor of the pituitary gland that produces adrenocorticotropic hormone and stimulates the adrenal cortex to increase its hormone secretion despite production of adequate amounts. Primary hyperplasia of the adrenal glands in the absence of pituitary tumor is less common. Another less common cause of Cushing's syndrome is the ectopic production of the adrenocorticotropic hormone by malignancies. Regardless of the case, the normal feedback mechanisms that control the function of the adrenal cortex become ineffective, and the usual diurnal pattern of cortisol is lost. Signs and symptoms of Cushing's syndrome are primarily a result of oversecretion of glucocorticosteroids and androgens, although minimal corticosecretion may be affected as well. Clinical presentation can be obesity, hyperglycemia, glycosuria, hypertension, fluid and electrolyte disturbances, and may have psychosocial issues due to the body image. Clinical manifestations include when overproduction of the adrenal hormone occurs, arrest of growth, obesity, and musculoskeletal changes occur along with glucose intolerance. The classic picture of Cushing's syndrome in the adult is that of essential type obesity with a fatty buffalo hump in the neck and supraclavicular areas, a heavy trunk, and relatively thin extremities. The skin is thin, fragile, and easily traumatized. Ecchymosis and striae developed. The patient complains of weakness. Sleep is disturbed because of altered diurnal secretion of cortisol. Excessive protein catabolism occurs, producing muscle wasting and osteoporosis. Kyphosis, backache, and compression fractures of the vertebrae may result. Retention of sodium and water occurs as a result of increased mineralocorticoid activity, producing hypertension and heart failure. The patient develops a moon-faced appearance and may experience increased oiliness of the skin and acne. Hyperglycemia or overt diabetes may result. The patient may also report weight gain, slow healing of minor cuts and bruises. In females of all ages, virilization may occur as a result of excess androgens. If Cushing's syndrome is caused by pituitary tumors rather than tumors of the adrenal cortex, treatment is directed at the pituitary gland. Surgical removal of the tumor is the treatment of choice and has an 80% success rate. Radiation of the pituitary gland also has been successful. Adrenalectomy is the treatment of choice in patients with primary adrenal hypertrophy. Adrenal enzyme inhibitors such as metoprolol, cytodren, and lisodren may be used to reduce hyperadrenalism if the syndrome is caused by the ectopic ACTH secretion by a tumor that cannot be eradicated. If Cushing's syndrome is a result of administration of corticosteroids, an attempt is made to reduce or taper the medication to the minimum dosage needed to treat the underlying disease process. Also, what is included is a nursing intervention for decreasing risk of injury, preventing the falls and fractures or other injuries to bones and soft tissues. Foods high in protein, calcium, and vitamin D are recommended to minimize muscle wasting and osteoporosis. Decreasing risk of infection is a nursing intervention, meaning the patient should avoid unnecessary exposure to others with infections. Preparing the patient for surgery if the patient is going for an adrenalectomy if indicated, and the postoperative course. If Cushing's syndrome is a result of a pituitary tumor, a transsphenoidal hypophysectomy may be performed. Diabetes and peptic ulcer are common in patients with Cushing's syndrome. Therefore, insulin therapy and medication to prevent or treat peptic ulcer are initiated if needed. Encouraging resident activity is an important nursing intervention. Although the patient with Cushing's syndrome experiences insomnia, weakness, fatigue, and muscle wasting, the nurse should encourage moderate activity to prevent complications of immobility and produce increased self-esteem. Promoting skin integrity with meticulous skin care is necessary to avoid traumatizing the patient's fragile skin. Improving body image, if treated successfully, with the major changes associated with Cushing's syndrome disappear in time. The patient may benefit from discussion of the effect of the change that has had on their self-esteem concept and relationship with others. With hypocorticosolism, or Addison's disease, it's an adrenal cortical insufficiency. It occurs when adrenal cortex function is inadequate to meet the patient's need for cortical hormones. Autoimmune or idiopathic atrophy of the adrenal glands is responsible for the majority of cases. Other causes include surgical removal of both adrenal glands and infection of the adrenal glands. Tuberculosis and histoplasmosis are the most common infections that destroy adrenal gland tissue. Although autoimmune destruction has replaced tuberculosis as the principal cause of Addison's disease, tuberculosis should be considered in the diagnostic workup. Therapeutic use of corticosteroids is the most common cause of adrenocortical insufficiency. Symptoms of adrenocortical insufficiency may result from the sudden cessation of exogenous adrenocortical hormone therapy, which suppresses the body's normal response to stress and interferes with normal feedback mechanisms. The clinical manifestations with Addison's disease is characterized by muscle weakness, anorexia, GI symptoms, fatigue, emaciation, dark pigmentation of the mucous membranes and the skin, especially of the knuckles, knees, and elbows, hypotension, and low blood glucose, low serum sodium, and high serum potassium levels. Depression, emotional liability, apathy, and confusion are present in about 20 to 40% of patients. In severe cases, the disturbance of sodium potassium metabolism may be marked by depletion of sodium and water and severe chronic dehydration. As the disease progresses, Addisonian crisis develops. This condition is characterized by hypotension, cyanosis, fever, nausea, vomiting, and classic signs of shock. The patient may have pallor, complain of headache, abdominal pain, and diarrhea, and may show signs of confusion and restlessness. The treatment and medical management is directed towards combating circulatory shock, restoring blood circulation, administering fluids and corticosteroids, monitoring vital signs, and placing the patient in a recumbent position with legs elevated. Hydrocortisone, or Solu-Cortef, is administered by IV, followed by a 5% dextrose and normal saline. Antibiotics may be administered if infection has precipitated adrenal crisis. Oral intake may be initiated as soon as tolerated. IV fluids are gradually decreased after oral fluid intake is adequate to prevent hypovolemia. If the adrenal gland does not regain function, the patient needs lifelong replacement of corticosteroids and mineralocorticoids to prevent recurrence of adrenal insufficiency. During stressful procedures or significant illness, additional supplemental therapy with glucocorticoids is required to prevent Addison crisis. In addition, the patient may need to supplement dietary intake with salt during GI losses of fluids through vomiting and diarrhea. In the concept of metabolism, there is an exemplar of Addison's disease. Within the Addison's disease, as disease progresses, Addisonian crisis develops. This condition is characterized by hypotension, cyanosis, fever, nausea, vomiting, and classic signs of shock. The patient may also have pallor, complain of headache, abdominal pain, and diarrhea. They may also show signs of confusion and restlessness. Even slight overexertion, exposure to cold, acute infection, or a decrease in salt intake may lead to circulatory collapse, shock, and death if untreated. The stress of surgery or dehydration resulting from preparation for diagnostic tests or surgery may precipitate an Addisonian or hypotensive crisis. The concept of sensory cataracts is an exemplar. A cataract is a lens opacity or cloudiness. It affects nearly 24.4 million Americans who are 40 years or older. Cataract is a leading cause of blindness in the world. The medical management would include the risk reduction of cataract formation, having the patient with smoking cessation, weight reduction, blood sugar control for diabetic patients, and wearing of sunglasses. Surgical intervention is an option. A no non-surgical treatment, such as medication, eye drops, or eyeglasses, cures cataracts or prevents age-related cataracts. The concept of sensory cataracts is an exemplar. A cataract is a lens opacity or cloudiness. It affects nearly 24.4 million Americans who are 40 years or older. Cataract is a leading cause of blindness in the world. The medical management would include the risk reduction of cataract formation, having the patient with smoking cessation, weight reduction, blood sugar control for diabetic patients, and wearing of sunglasses. Surgical intervention is an option. A no non-surgical treatment, such as medication, eye drops, or eyeglasses, cures cataracts or prevents age-related cataracts. With the exemplar of cataracts, there is surgical management, and there's a teaching chart, 63.9, in your Hinkle ebook under Home Care Checklist, page 1861. It suggests for the patient to wear glasses or eye shields after surgery, avoid lying on the side of the affected eye, keeping activity light, avoiding pushing, lifting objects heavier than 15 pounds, and definitely knowing when to contact the ophthalmologist. They need to contact the ophthalmologist if they have any vision changes, continuous flashing lights, redness, pain, or swelling that increases in the affected eye drainage changes, eye that gets injured, and pain not relieved by acetaminophen. Within the concept of sensory, the exemplar conductive hearing loss has many factors. Numerous factors contribute to the hearing loss. Noise-induced hearing loss refers to hearing loss that follows a long period of exposure to loud noise, such as heavy machinery, engines, artillery, rock band music. Acoustic trauma refers to hearing loss caused by single exposure to an extremely intense noise, such as an explosion. Usually noise-induced hearing loss occurs at a high frequency. However, with continued noise exposure, the hearing loss can become more severe and include adjacent frequencies. In Chart 64.4, communicating with people who are hearing impaired, there are many opportunities to understand and learn how to communicate with people who are hearing impaired. Determine how the person prefers to communicate with others. Consider if the person uses sign language, if they need an interpreter. Devote full attention to what the person is saying. Look and listen. Do not try to attend to another task while listening. Try to determine the essential content of what is being said. Do not try to appear as if you understand and you do not. Written communication is an excellent resource. Before communicating, it's best to reduce noise or distractions. And during examinations and testing, be aware that the patient may not hear instructions. They may not read lips, see a signer, or even be able to read written material in dark rooms. Within the concept sensory, there is macular degenerative disease as an exemplar. Age-related macular degeneration is the most common cause of visual loss in people older than 65 in the United States. It's characterized by tiny yellowish spots called drusen beneath the retina. Most people older than 60 have at least a few small drusen, which are clusters of debris or waste material. When drusen are located in the macular area, they can affect vision. There is no cure for the dry, non-exudate type of macular degeneration. The National Eye Institute is sponsoring an ongoing clinical trial to study the effect of lutein in carotenoids or fish oils in protecting the macula and preventing the progression of macular degeneration. Wet exudate is characterized by the development of an abnormal choroidal neovascular network beneath the macula. These vessels leak fluid and bleed, causing edema and the development of fibrosis. If either the dry or the wet are not cured, it will result in a loss of central vision. In nursing management, an Amsler grid is given to patients to use in their homes to monitor for a sudden onset or distortion of vision. They may provide the early sign that macular degeneration is getting worse. Patients should be encouraged to look at these grids, one eye at a time, several times each week, with glasses on if needed for corrected near vision. If there is a change in the grid, meaning the lines or squares appear distorted or faded, the patient should notify their ophthalmologist immediately and should arrange to be seen promptly. With the concept of sensory, the exemplar peripheral neuropathy will be explained. Now, there is diabetic neuropathy, which refers to a group of diseases that affects all types of nerves, including peripheral, sensorimotor, autonomic, and spinal nerves. The disorder appears to be clinically diverse and depends on the location of the affected nerve cells. The etiology of neuropathy may involve elevated blood glucose levels over a period of years. Control of blood glucose levels to normal or near normal levels decreases that incidence of neuropathy. The pathogenesis of neuropathy may be attributed to either a vascular or metabolic mechanism or both. Capillary basement membrane thickening and capillary closure may be present. In addition, there may be demyelinization of the nerves, which is thought to be related to hyperglycemia. Nerve conduction is disrupted when there are aberrations of the myelin sheaths. The clinical manifestations will include initial symptoms that could include paresthesia, which is prickling, tingling, or heightened sensation, burning sensations, especially at night, and as the neuropathy progresses, the feet become numb. In addition, a decrease in proprioception, which is the awareness of posture and body movement and the weight of objects in relation to the body, and a decreased sensation of light touch may lead to an unsteady gait. On physical examination, a deep tendon reflex and vibratory sensation is found. For patients who have few or no symptoms of neuropathy, these physical findings may be the only indications of neuropathic changes. Within the management, we would like the patient to have intensive insulin therapy and control of blood glucose levels so that it will delay the onset and slow the progression of neuropathy. Pain, particularly of the lower extremities, is a disturbing symptom in some people with neuropathy secondary to diabetes. There have been various approaches to pain management, and they have been tried. Such can be non-opioid medications, tricyclic antidepressants, anti-seizure medications, antiarrhythmic agents, and transcutaneous electrical nerve stimulation. With the concept of coping, peptic ulcer disease exemplar is an excavation, which is a hollowed-out area that forms a mucosal wall of the stomach or pylorus or duodenum or esophagus caused by erosion. This erosion may extend to the peritoneum. The pathophysiology of peptic ulcer disease is that of a bacteria called H. pylori. A risk factor is the use of NSAIDs such as ibuprofen and aspirin. There are predisposing factors such as familial tendency for peptic ulcer disease, and peptic ulcer disease with rare cases are patients with tumors. Peptic ulcers occur mainly in the gastroduodenal mucosa because this tissue cannot withstand the digestive action of gastric acid and pepsin. The erosion is caused by the increased concentration or activity of acid pepsin or by decreased resistance of the mucosa. A damaged mucosa cannot secrete enough mucus to act as a barrier against this activity of acid pepsin. Nutrition is important to maintain health and to prevent disease and death. When illness or injury occurs, optimal nutrition is essential for healing and for resisting infection and other complications. Components of a nutritional assessment: there is a sequence of assessment parameters that may vary. However, evaluation of nutritional status includes these following methods: measurement of body mass index, or the BMI, waist circumference, biochemical assessment, clinical examination findings, and dietary data. The measurement of BMI and waist circumference is recommended to determine if a patient is obese. The BMI ratio based on base body weight and height. The obtained value is compared to the established standards. The BMI is highly correlated with body fat, although increased lean body mass or a large body frame can also increase the BMI. In nutrition, it's important to consider lifespan considerations. Adolescence is a time of critical growth and when lifelong eating habits are established. Nutritional assessment is particularly important during this time period. It is vital to assess for obesity in adolescents to prevent complications from obesity as they enter adulthood. Adolescent girls are at a particular nutritional risk because iron, folate, and calcium intakes are below recommended levels, and they are less physically active group compared to adolescent males. Adolescents with other nutritional disorders such as anorexia and bulimia have a better chance of recovery if these disorders are identified and treated in the adolescent years rather than the adulthood. Gastrostomy and enteral feedings are exemplar under nutrition. Gastrointestinal intubation is the insertion of a flexible tube into the stomach or beyond the pylorus into the duodenum or the jejunum. The tubes may be inserted through the mouth, the nose, or the abdominal wall. The tubes are obviously of various diameters and length depending on their intended use. The purpose of GI intubation may be performed in order to decompress the stomach and remove gas and fluid, lavage, which is flush with water or other fluids and remove ingested toxins or other harmful materials, diagnose GI disorders, administer tube feedings, fluids, and medications, compress a bleeding site, or aspirate GI contents for analysis. The different types of tubes depend on the diagnosis. Within these tubes, we do nursing management. We prepare the patient prior to the insertion to promote cooperation during the procedure. Once placed, we confirm placement. To ensure patient safety, it's essential to confirm the tube has been placed correctly. The tip of the tube may be in the esophagus, stomach, or small intestine. It may also inadvertently be inserted in the lungs, most commonly in the right main stem bronchus. Inappropriate placement may occur in patients with decreased level of consciousness, confused mental states, poor absent gag, or cough reflexes, or agitation during insertion. Also, what must be assessed is clearing tube obstruction. If it's difficult to instill withdrawal warm water into a clogged feeding tube, several declogging steps can be taken, including warm water penetration, milking the tube, infusing digestive enzymes, and employing mechanical declogging devices. When the tube is first noted to be clogged, a 30 to 60 ml syringe should be attached to the end of the tube and any contents aspirated and discarded. Then the syringe should be filled with warm water, attached to the tube again, and a back and forth motion initiated to help loosen the clog. Clearing tube obstructions is essential so that medications can be input or drainage can be expelled. Also, the nurse must provide oral and nasal hygiene. It is essential to have regular conscious oral and nasal hygiene because the tube causes discomfort and pressure and may be in place for an extended length of time. The nose is inspected daily for irritation and the tape is changed every 2 to 3 days. The nurse must also monitor and manage potential complications. Patients with these NG intubations are susceptible to a variety of problems, including fluid volume deficit, pulmonary complications, and tube-related irritations. These potential complications require careful ongoing assessment. Before inserting the tube, the nurse determines the length that will be needed to reach the stomach or the small intestine. A mark is made on the tube to indicate the desired length. This length is determined by measuring the distance from the tip of the nose to the earlobe and from the earlobe to the xiphoid process. During insertion, the patient usually sits upright with a towel or other protective barrier, like a bib-like fashion over the chest. The nostril may be swabbed or the oropharynx sprayed with an anesthetic agent to numb the nasal passage and suppress the gag reflex.